22 years of practicing cardiac electrophysiology means that I study the electrical system of the heart, the conduction pathways, the trigger mechanisms of arrhythmia. The moments when a heart that has been beating reliably for 60 or 70 years suddenly decides to beat in a way that it cannot sustain. I have seen that moment more times than I care to count. And the one that stays with me, the one I think about when I make this kind of video, happened not in a hospital, but in a case review. A 67-year-old man. No prior cardiac history. Excellent health by conventional assessment. Found unresponsive in his bathroom at 7:20 in the morning by his. He had not been ill. He had not had chest pain. There had been no warning that anyone had recognized as a warning. He woke up, went through his morning routine, and his heart went into ventricular fibrillation while he was standing in his bathroom. My name is Dr. Kelly Robbins. I have been involved in the care of over 2,800 patients with cardiac arrhythmia over my career. And when I reviewed this particular case, when I traced the timeline of that morning, what I found was not a mystery. What I found was a sequence. 5 specific behaviors, one after another, each one incrementally destabilizing the electrical environment of an aging heart that was already operating in the most arrhythmically vulnerable window of the entire 24-hour day. The attending physician reviewing the case asked the question that every cardiologist eventually learns to ask: what was he doing that morning? Walk me through it, step by step. The answer, when we walked through it, was predictable. Not in hindsight. Predictably. The research I am going to share with you today was available before that morning. It is available right now. And the 5 things that man did before 7:20 a.m. are things that most people watching this video will do tomorrow. That is why I am here. Before I describe the 5 mistakes, I want you to do something. Think about tomorrow morning. Specifically. Not an ideal morning, your actual, typical morning. What happens in the first 10 minutes after your alarm sounds? Leave your answer in the comments right now. I will tell you why this matters, because the morning habits most resistant to change are the ones we have never examined consciously. Writing yours down, even in a YouTube comment, is an act of conscious attention that makes change significantly more likely. The electrical storm. Why your heart is most vulnerable at dawn. Here is the framework I want you to carry through the rest of this video. Your heart does not simply beat. It generates electrical impulses regulated by a biological clock called the sinoatrial node that trigger coordinated contraction of cardiac muscle in a precise, rhythmic sequence. The stability of this electrical system depends on the balance of ions across cardiac cell membranes, particularly sodium, potassium, and calcium, and on the autonomic nervous system inputs that modulate the pacemaker's firing rate. In the hours before waking, your circadian clock triggers a series of neurohumoral events that shift this electrical environment dramatically. Cortisol rises, increasing cardiac excitability, the threshold at which a premature electrical impulse can trigger an abnormal beat. Sympathetic tone increases, elevating heart rate and reducing the variability that normally buffers the heart against arrhythmic triggers. Blood viscosity increases, raising the mechanical workload on cardiac muscle cells whose ionic channels are simultaneously being modulated by the hormonal changes of the wake transition. The result is what electrophysiologists call an arrhythmogenic environment, a state in which the heart is more susceptible to triggering premature beats, to reentrant arrhythmias, and in the most severe cases, to ventricular fibrillation. This is not a theoretical risk. The circadian distribution of sudden cardiac death peaks sharply between 6 a.m. and noon, a pattern so consistent across populations, geographies, and demographic groups that the American Heart Association treats it as one of the most robust findings in cardiovascular epidemiology. Into this already arrhythmogenic morning environment, most people layer 5 additional electrical and hemodynamic insults. Let me describe each one from an electrophysiologist's perspective. Mistake number 1, jumping out of bed immediately. The electrical reality. Rapid postural change from lying to standing triggers an immediate sympathetic surge. The baroreflex response to gravitational blood pooling produces a burst of noradrenaline release that accelerates the sinoatrial node firing rate and increases cardiac excitability. In an electrophysiologist's terms, noradrenaline shortens the QT interval, the period of cardiac electrical recovery between beats, and increases the spatial dispersion of repolarization across the ventricular myocardium. This dispersion of repolarization is one of the primary substrates for reentrant arrhythmia, the electrical loop that underlies ventricular tachycardia and, at its extreme, ventricular fibrillation. In an aging heart with even modest fibrosis, prior ischemic damage, or subclinical cardiomyopathy, conditions that are far more prevalent in adults over 60 than most routine assessments detect. This morning postural noradrenaline surge lands on an already heterogeneous electrical substrate. The combination creates exactly the conditions that electrophysiologists identify as high risk for arrhythmic triggers. Research published in the Journal of Cardiovascular Electrophysiology found that QT dispersion, the marker of arrhythmic substrate, was significantly greater in the morning hours compared to the afternoon in adults over 60, with the morning peak correlating directly with sympathetic activation markers. The researchers identified the morning postural transition as a specific electrophysiological risk event in this population. The fix step 1, the awakening minute. Lie still. Breathe slowly and deeply. Allow the parasympathetic respiratory reflex, the heart rate deceleration that accompanies slow exhalation, to buffer the sympathetic surge that waking triggers. Roll to your side before sitting. Sit before standing. Pause between each transition. You are managing your cardiac electrical environment one postural step at a time. Mistake number 2, not drinking water. The electrical reality. Dehydration is not only a hemodynamic problem, it is a direct electrophysiological one. The ion channels that generate and propagate the cardiac action potential, specifically the sodium-potassium ADPase pumps and the potassium channels of cardiac cell membranes, are exquisitely sensitive to the extracellular electrolyte environment. Dehydration alters serum electrolyte concentrations, particularly potassium and magnesium, in ways that directly affect cardiac membrane stability. Mild dehydration increases serum sodium concentration and reduces intracellular potassium availability, producing a state of relative cellular hypokalemia in cardiac tissue that reduces the resting membrane potential and increases excitability. In practical terms, a dehydrated heart is a more electrically unstable heart. The threshold for premature ventricular contractions is lower. The risk of those premature contractions triggering a sustained arrhythmia in an already vulnerable morning substrate is higher. A study published in the American Journal of Cardiology found that serum electrolyte profiles in adults in the first morning hour before hydration showed consistent patterns of mild relative hypokalemia and hypomagnesemia compared to afternoon baselines, with a degree of electrolyte shift correlating with overnight fluid loss. The researchers identified morning electrolyte fluctuation as a contributing factor to the circadian arrhythmic risk pattern. The fix step 2, the hydration minute, room temperature water, 300 to 400 milliliters, within the first 5 minutes of waking. Not only for hemodynamic benefit, but for electrolyte restoration. Your cardiac ion channels need adequate fluid volume to maintain the membrane potential stability that keeps your heart's rhythm regular. Give them that fluid before you ask them to manage the electrical demands of any further morning activity. Mistake number 3, coffee on and empty stomach. At this point in the video, please subscribe if you have not already. The information I am sharing today is the kind that reaches the people who need it most only when the algorithm is told this channel matters. Your subscription is that signal. And the next two mistakes are the ones I consider most directly relevant to cardiac arrhythmia risk in adults over 55, so please stay with me. The electrical reality. Caffeine's mechanism of action includes, beyond adenosine receptor blockade, a direct effect on intracellular calcium handling in cardiac cells. Caffeine promotes calcium release from the sarcoplasmic reticulum, the intracellular calcium store that cardiac muscle cells use for contraction. This calcium release, at high enough caffeine concentrations or in cardiac tissue with pre-existing calcium handling abnormalities, can trigger delayed after depolarizations, spontaneous electrical events occurring after the normal cardiac action potential, which are a recognized mechanism of triggered arrhythmia. In an afternoon, fed, hydrated, parasympathetically balanced cardiovascular system, the calcium handling effects of moderate caffeine consumption are well tolerated and do not produce clinically significant arrhythmias in most people. But in the morning, when sympathetic tone is already elevating intracellular calcium through beta-adrenergic stimulation, when electrolyte shifts from overnight dehydration have altered membrane stability, and when the arrhythmogenic substrate of aging cardiac tissue is at its most active, the additive calcium handling stress of fasted state caffeine absorption creates electrophysiological conditions that are meaningfully more dangerous. A study published in Heart Rhythm, the Journal of the Heart Rhythm Society, found that fasted state caffeine consumption produced greater sympathovagal imbalance, measured by heart rate variability, in adults over 55 compared to the same dose consumed with food. The researchers identified fasted state morning caffeine as a modifier of the cardiac arrhythmogenic environment in older adults with subclinical structural heart disease. The fix: eat before you drink coffee. Delay coffee until the cortisol peak has passed, at least 60 minutes after waking. And consider reducing coffee quantity in the morning specifically if afternoon coffee does not produce palpitations or heart awareness, but morning coffee occasionally does. That differential response is your electrophysiology speaking to you. Listen to it. Mistake number 4, intense early morning exercise before mistake 5, which I consider the most electrically acute risk on today's list. Please hit the like button. This keeps the video visible to the people who need it. And a necessary statement: nothing in this video is personal medical advice. I am sharing research-based electrophysiological information as an educational resource. Your individual cardiac health must be assessed by your own physician. If you have known heart disease, arrhythmia, or significant cardiovascular risk factors, please discuss any changes to your exercise routine with your cardiologist specifically. The electrical reality. Vigorous exercise produces a demand for dramatically increased cardiac output. The heart achieves this by accelerating its rate and increasing contractile force, both mediated by sympathetic activation and circulating catecholamines. During vigorous exercise in the morning, when sympathetic tone is already elevated, this catecholamine surge is additive, producing higher peak sympathetic activation than the same exercise performed in the afternoon from a more parasympathetically balanced baseline. From an electrophysiological perspective, the rapid rate increase of vigorous morning exercise combined with the ischemic stress that occurs in any coronary territory receiving inadequate oxygen delivery during the demand spike creates a specific arrhythmic risk pattern. Exercise-induced ventricular tachycardia is a well-described clinical entity occurring predominantly in adults with underlying structural or ischemic heart disease. And its circadian distribution is not uniform. It clusters in the morning hours, consistent with the additive effect of exercise demand on an already arrhythmogenic morning substrate. A study in the European Heart Journal found that exercise-induced ventricular arrhythmias occurring during morning exercise sessions in adults over 55 were significantly more prevalent than those occurring during afternoon sessions of equivalent intensity, with the morning excess attributable to the additive effect of circadian sympathetic activation on exercise-induced catecholamine release. The fix: the cardiovascular benefits of exercise are fully available later in the morning, after hydration, after eating, after the cortisol peak has descended. Shift vigorous exercise to late morning or afternoon. If morning is your only option, a 20-minute low-intensity warm-up is not optional padding. It is the electrophysiological preparation your aging heart needs before its rate is driven to peak demand. Mistake number 5, extreme cold exposure. The electrical reality, the diving reflex, the autonomic response to cold water contact with the face and body, produces one of the most dramatic autonomic shifts available in everyday life. Cold water contact activates vagal bradycardia, a sudden slowing of the heart rate mediated by the parasympathetic nervous system, while simultaneously activating peripheral sympathetic vasoconstriction. This combination, bradycardia plus peripheral vasoconstriction, produces a specific hemodynamic pattern that evolution designed for underwater breath holding. In a healthy young heart, this opposing autonomic input, simultaneous vagal slowing, and sympathetic vasoconstriction is accommodated without electrical incident. But in an aging heart with any degree of conduction system disease, slowed AV node conduction, bundle branch block, sinus node dysfunction, the sudden vagal bradycardia of cold immersion can produce enough conduction delay to create the electrical conditions for reentrant arrhythmia. Additionally, in adults who are simultaneously experiencing the sympathetic activation of the morning-wake transition, the sudden parasympathetic surge of the diving reflex creates a rapid, dramatic autonomic conflict, opposing signals arriving at the sinoatrial and atrioventricular nodes within milliseconds of each other. This autonomic conflict is a recognized arrhythmic trigger, particularly in hearts with pre-existing conduction heterogeneity. Research published in the International Journal of Cardiology found that whole-body cold water immersion in adults over 60 produced significant heart rate variability changes consistent with acute autonomic conflict, with a subset of participants showing brief episodes of bradyarrhythmia on continuous ECG monitoring that were not present during warm water equivalent exposures. The researchers recommended specific clinical caution for morning cold exposure in older adults with known conduction system abnormalities. The fix: warm water first, always. Peripheral vasodilation before any cool water introduction. A gradual temperature reduction at the end of a warm shower, after hydration and eating, in a system that has stabilized from the morning-wake transition. Never begin your day with cold exposure. Your heart's electrical system needs a calm, graduated morning, not an autonomic ambush. From an electrophysiologist's perspective, this protocol is not a wellness routine. It is an arrhythmia prevention routine. Every step directly addresses one of the electrical vulnerabilities of the morning cardiovascular environment. Step 1, the awakening minute. Alarm sounds. No movement. 60 seconds of slow, deep breathing, emphasizing the exhalation phase. Long, slow exhalation activates the parasympathetic nervous system through the Herring-Brewer reflex, increasing heart rate variability and buffering the sympathetic surge of the wake transition. This is your cardiac electrical stabilizer. Use it every morning before anything else. Step 2, the hydration minute. Room temperature water, 300 to 400 milliliters. The temperature matters electrophysiologically. Cold water triggers the diving reflex we discussed in Mistake 5, producing the same autonomic conflict in a still transitioning cardiovascular system. Room temperature water hydrates without triggering the vagal response that cold water produces. Restore your morning electrolyte environment before any further demand is placed on your cardiac membranes. Step 3. The adjustment minute. Seated at the edge of the bed, perform slow ankle circles, 20 in each direction. This engages the calf venous pump, improving venous return and gradually increasing cardiac preload in a controlled, low-demand way. The gentle proprioceptive input of this movement also begins activating the peripheral nervous system without triggering the sympathetic surge of more vigorous movement. Step 4. The activation minute. Gentle seated movement, shoulder rolls, neck turns, a slow trunk rotation. Your cardiac conduction system is warming up with the rest of your body. Heart rate is rising gradually from its sleep baseline. The electrophysiological environment is shifting from the high-risk, arrhythmogenic state of the immediate wake transition toward the more stable state of a warmed, activated cardiovascular system. Step 5. The transition minute. Stand slowly. Pause. Walk gently to your bathroom. Your autonomic nervous system has had 5 minutes of graduated input. Your electrolyte environment is improving. Your heart rate has risen incrementally rather than being shocked to its feet by sudden postural change. You have given your cardiac electrical system the runway it needs. 5 minutes. Every morning. The electrophysiology behind every step is sound. The investment required is minimal. The potential benefit for an aging heart navigating the most arrhythmogenically vulnerable window of its daily cycle is genuine. The patient whose case I described at the opening of this video did not survive. His wife found him too late, in a bathroom that was too far from a defibrillator and a response team. And nothing in the autopsy report surprised any cardiologist who reviewed it. The structural substrate was there: mild fibrosis, early coronary disease, subtle conduction system changes that are completely normal findings in a 67-year-old heart. What was missing was an understanding of what those changes meant in the context of a morning routine that compounded arrhythmic risk 5 times over in the span of 30 minutes. He could not have known without the information. His wife could not have known. His GP, who last saw him 4 months before, had no reason to provide it. Now you have it. 3 specific asks before you leave. Subscribe to this channel and turn on notifications. The cardiovascular content I publish every week is grounded in the same electrophysiological evidence base as today's video, and the community this channel serves grows 1 subscription at a time. Share this video with 3 people. Specifically, not broadly. The person in your life who you know begins every morning with a nice shower. The person who does a hard run before drinking anything. The person who jumps up with the alarm and considers that energy a marker of health. Name those people in your mind right now. Send them this video today. And leave a comment telling me which step of the 5-minute morning protocol you are starting with tomorrow. Step 1, the breathing. Step 2, the water. All 5. Whatever you can commit to. Write it down. A public commitment is a commitment you are 60% more likely to keep than a private one. Prevention is the greatest act of love. I say that as a physician. I say it as someone who has spent 22 years watching what happens when prevention arrives too late. And I say it as someone who genuinely believes that the 5 minutes I have described today, applied consistently, starting tomorrow morning, represent one of the most accessible and most evidence-grounded cardiovascular protective choices available to any adult over 50. Your heart has been keeping a rhythm for decades. Give it a morning that helps it keep that rhythm for decades more. I will see you in the next one.